Good evening all. Welcome to the class. So today we will discuss thalassemia in pregnancy, beta thalassemia in pregnancy. There are two anemias which we are going to discuss, or hemoglobin related disorders. One is a sickle cell disease and second is thalassemia. Sometimes the students do get confused in the clinical feature of thalassemia and the management of the sickle cell disease, but we'll make it clear how these two things are different, okay, and what is important in which condition, okay. What are the types of thalassemia? We'll finish with the thalassemia first. What are the types of thalassemia? Clinically, it is either thalassemia major, thalassemia intermedia, or thalassemia trait, or thalassemia minor, what we call it as. So if the patient requires the blood transfusion of more than 7 transfusions per year, that is a transfusion dependent, it is thalassemia major. If the transfusion requirement is less than or equal to 7 per year, then or no transfusion, then it is a thalassemia intermedia. While thalassemia trait is just a carrier where there is a mild anemia and no transfusion is required in these particular cases. Okay, so what happens in the pathophysiology of thalassemia is there is a decreased globin chain synthesis that leads to the reduction in the hemoglobin and which leads to the ineffective erythropoiesis. Okay, so there is an extravascular hemolysis and there is a chronic anemia and there is expansion of the marrow. The patient requires a multiple transfusion because the hemoglobin level is low, so there is an iron overload, and this iron overload is the one important thing which is happening in thalassemia, which is not much in the sickle cell disease. Okay, so in the heart there is a cardiomyopathy leading to the cause of death. One of the important cause of death in patients with sickle cell disease is the heart failure or cardiomyopathy. Second is endocrine, leading to the hypogonadism, diabetes, hypothyroidism. Okay, and in liver it causes cirrhosis, and this is because of the iron overload. The iron gets deposited. Okay, so what are the risks in pregnancy in patients with thalassemia? Maternal, there can be cardiomyopathy. In endocrinopathies can be there, that is diabetes mellitus, hypothyroidism, hypoparathyroidism, and there will be subfertility mainly because of the hypogonadotrophic hypogonadism. Okay, so in fetus there will be FGR, and this is FGR will be there, and there is a possibility of the genetically transmission of the disease. Okay, so coming to the preconceptional counseling, this is very important in thalassemia. So it is the multidisciplinary care. The patient is managed along with the hematologist. So obstetrician plus hematologist will manage the case, and we need to assess one, iron overload. Second, is there any organ damage? If it is there, what is the extent of organ damage and what is the fertility status? That is the main which is done in the preconceptional counseling. Okay, so presence of iron overload, end organ damage, and what is the fertility status. Okay, so how we are going to assess the iron overload, that we will discuss. Okay, in the heart, we have to get the 2D echo done, echocardiogram done, and it is the special T2 MRI. Okay, so this T2 MRI will tell us about the iron overload. Okay, so if the T2 MRI is more than 20 millisecond, that is ideal. Okay, so T2 MRI showing more than 20 ms, that means there is a low iron overload, okay, or no iron overload. Then endocrinopathy, we need to screen for the diabetes. These patients are to be screened for the diabetes. Here HbA1c is not useful. This is important from SBA point of view. What is used for screening for diabetes is a fructosamine, and the level of the fructosamine should be less than 300 nanomole per liter. Remember, thalassemia screening for the diabetes is done with serum fructosamine, and the level should be less than 300 nanomole per liter. Thyroid function, the patient should be euthyroid. Then liver, here also we need to look for the deposition of the iron. Okay, so there is a special ferry scan or liver T2 scan is there. The ideal level should be less than 7 milligram per gram dry weight. Okay, so normal it should be less than 7 milligram per gram dry weight of the liver. That is normal and does not suggest iron overload, while T2 more than 20 ms is normal. Okay, so here this is less than 7 milligram per gram is normal. Here it is more than 20 ms is ideal, okay, or normal. Then we need to get the DEXA scan also done to look for any osteoporosis, and blood should be looked for any antibody because the patient is receiving multiple transfusion. So to detect alloimmunization, the antibody screening is to be performed. So as I have already discussed, the T2 should be less than 10 ms is high risk for cardiac failure. So it should be more than 20 ms, that is normal. And if your value is T2 value is less than 10 ms, that indicates there is a high risk for the cardiac failure because of the cardiac ion deposition. Okay, so there will be decreased ejection fraction, relative contraindication to the pregnancy. So cardiology review is mandatory. Now coming to the chelation therapy, because we are concerned about the iron overload, the iron which is there excess needs chelation therapy. Now, there are three agents which can be used, out of which only desferrioxamine is safe in pregnancy. That is also 20 weeks or second and third trimester onwards. You can start the patient on desferrioxamine. While other, like that is deferricerox and deferriprone, they are to be stopped 3 months before the conception. So in the preconceptional counseling, we need to check one, fertility status, second, iron overload. We need to get the investigations done. We need to find out whether she is receiving any iron chelation therapy, and if she wants to conceive, in that case we need to stop this chelating agent 3 months prior. Okay, and during pregnancy we will restart again, but in the second trimester onwards, and that also desferrioxamine. Okay, so that is the safe agent. Then coming to the first trimester, all chelation agents are contraindicated. So pregnancy increases the iron burden. Pregnancy increases the iron burden and needs chelation is to be stopped. So what is the genetic counseling is required? If the partner is carrier or affected, the, in that particular case, there is a prenatal diagnosis, pre-implantation genetic diagnosis is required. IVF ICSI is to be suggested. So if both partners are affected, the risk of having the affected child is high. Okay. So if the partner is carrier or affected, we need to offer prenatal diagnosis, pre-implantation genetic diagnosis with IVF and ICSI. Okay. Then coming to the fertility, there will be subfertility due to the hypogonadotropic hypogonadism, and the patient will require ovulation induction by gonadotropics. Then contraception. All methods of contraception are safe. Here we can use oral contraceptives. That means the estrogen is not contraindicated. Then POPs, implant, LNG IUS, all can be used. Unlike sickle cell disease, where estrogen are not preferred. Okay, so here there is no restriction on the use of estrogen, while in sickle cell disease, they are second line. Okay, so in preconception intervention, what we should do? Aggressive iron chelation before pregnancy, check for cardiac status, endocrine function, and liver iron. Chelation is to be stopped in pregnancy. That leads to the increase in the iron, so there can be complications. Okay, so and for genetic counseling, we need to check the carrier status of the partner. Okay, so if the partner is a carrier for this particular condition, then there is a risk of serious hemoglobinopathy. Okay, so if you see the partner status, if it is HBC, then there is a mild to moderate disorder, while rest of the hemoglobinopathies, whether the partner is a carrier for beta thalassemia, HBS, HBE, delta beta thalassemia, HB leopard, HBO Arab, HB constant spring, there is a risk of serious hemoglobinopathy to the offspring. Only HBC is a mild to moderate disorder. Okay, so if the partner is HBC, in that particular case, offspring can have mild to moderate disorder. Then if both parents carry hemoglobinopathy, that means both parents are carrier, then there is a 25% risk of affected child. Okay, so there can be homozygous beta thalassemia, that is thalassemia major, or there can be compound heterozygous, that is a severe disease, HBS or beta thal, depending upon the partner status. Okay. Then coming to the immunization and hospital antibiotic prophylaxis. So as far as immunization is concerned, hepatitis B vaccination is required if the patient is HBs AG negative and patient is getting the transfusion or likely to receive the transfusion, then hepatitis B vaccination is mandatory. Then hepatitis C screening is to be done, perform HCV antibody testing, and if it is positive, check the RNA titer and the hepatology referral will be required. Okay. Then post splenectomy care. If the patient has undergone splenectomy, then the patient is prone to develop infection due to the encapsulated organisms like Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitis. So these are the organisms which are common. These can be asked in the SBA. Okay, so encapsulated organisms such as Streptococcus pneumoniae, Haemophilus influenzae type B, and Neisseria meningitis infection can be there. So prophylaxis will be daily penicillin, and if the patient is allergic, then erythromycin is to be used. And we have to consider the vaccination for pneumococcal vaccine. Every 5 years, the vaccine is required, and H influenza type B and meningococcal C, it is the single dose. Okay, so this, especially in the part 3, when you have the station of beta thalassemia, we need to ask this particular history, that whether the patient has received the pneumococcal vaccine and when she has received the vaccine, and whether she has received the Haemophilus influenza type B and meningococcal C vaccine or not. Okay. Coming to the vitamin supplementation, folic acid high dose 5 milligram will be required. That should be started at least 3 months before the conception. And high dose is required because there is increased erythropoiesis and the folate requirement is high. Then what is specific in the antenatal care? It should be under specialist care. Follow-up schedule is monthly till 28 weeks of gestation, and after 28 weeks, she will follow up every 2 weeks. It is the multidisciplinary team care constituting of obstetricians, midwife, and hematologist, along with cardiologist and the diabetologist. So we need to monitor the diabetes. Monthly serum fructosamine levels are to be done. Cardiac disease, cardiologist review at 28 weeks of gestation, and for hypothyroidism, serial TFTs are to be monitored. Okay. So coming to the ultrasound, which are done in these patients. So early viability scan around 7 to 9 weeks of gestation. Then NT scan as usual 11 to 14 weeks of gestation. Anomaly scan around 18 to 20.6 weeks of gestation. And growth scan will be required every 4 weekly from 24 weeks of gestation, as the FGR can happen in these patients. So risk of FGR due to the chronic anemia. Okay. Then coming to the management of the transfusion. So this thalassemia major patient will require regular transfusion. So regular transfusion is mandatory, and target for these patients is hemoglobin should be maintained at least 10 or more. Then patients of thalassemia intermedia, they are not on regular transfusion. So when to transfuse for patients with thalassemia intermedia, if the maternal anemia is worsening or if there is evidence of FGR, their target will be again to maintain the hemoglobin more than 10 gram per liter. And if uh, initially 2 to 3 units can be given, and HB should be aim should be to keep it above 12 gram per deciliter or 120 gram per liter. Then late pregnancy strategy, HB should be more than 8 gram per liter at 36 weeks if she is not on no need of transfusion, and HB is if less than 8 gram per deciliter, then top up transfusion at 37 to 38 weeks is required. Coming to the antenatal thromboprophylaxis, high risk groups are the splenectomy patients, and if they have undergone splenectomy and the platelet count is more than 6 lakh, in that particular case, what is the management? So look here, they can ask you the SBA. If the patient has got splenectomy or the patient has got high platelet, then only the aspirin 75 milligram is required. If the patient has undergone splenectomy and the platelet count is more than 6 lakhs, then aspirin plus LMWH is required. And in any hospital admission, patient will be on LMWH. Okay. So if the patient has undergone splenectomy, but the platelet is normal, then only we need to consider aspirin. Okay. Then splenectomy, but platelet is more than 6 lakh, then aspirin plus LMWH is required. And any hospital admission, we will start LMWH. Okay. So these are the abnormal RBC fragments that leads to the increased thrombosis risk. Okay. Coming to the ion chelation therapy. So we need to consult the hematologist, and in the first trimester, chelation therapy is avoided because there is a possibility of the teratogenicity. Then coming to the cardiac ion, we have already mentioned that we will screen these patients for cardiac ion overload, and T2 MRI is performed. If it is more than 20 milliseconds, then it is low risk. If it is between 10 to 20 milliseconds, then it is a moderate risk, and less than 10 milliseconds is the high risk for the cardiac failure. So these high risk patients will require chelation therapy. So desferrioxamine 20 milligram per kg per day to be started and start after 20 weeks of gestation. Okay, somewhere between 20 to 24 weeks of gestation, this chelation therapy will be started. So clinical red flags will be breathlessness, orthopnea, PND, palpitation, syncope. That will suggest there is a cardiac decompensation. For liver iron, we have already mentioned that ideally the level should be less than 7 milligram per gram of dry weight, and the high risk patients will be more than 15 milligram per gram. We need to consider desferrioxamine after 20 weeks for these patients also, where there is a iron overload in the liver. Now, what is the care which is given in the intrapartum care? Timing and mode of delivery. As per the standard obstetric indications, there is no specific restriction due to thalassemia. Okay, so vaginal delivery is permitted for these particular patients. There is no indication for cesarean section. So intrapartum, it is again a multidisciplinary team management. Cross-match blood if the hemoglobin is less than 10 gram per deciliter and antibodies are present. Continue with CTG monitoring. So it is a continuous CTG monitoring which is required. Active management of the third stage will be done. Okay, special intervention. Desferrioxamine will be given during the labor. 2 gram over a period of 24 hours needs to be given, and this will prevent the free radical damage and the arrhythmias. So mode of delivery, thalassemia is not an indication for cesarean section. Vaginal delivery is preferred. Postpartum, there is a VTE risk. So we will continue with thromboprophylaxis. If she has undergone vaginal delivery, it is for 7 days. And if she is undergone cesarean section, it is for 6 weeks. Please remember, this can be asked in the SBA. Patients with thalassemia, if she has undergone vaginal delivery for 7 days and cesarean section for 6 weeks. Okay. Breastfeeding is safe and encouraged. Desferrioxamine is safe. It is not orally absorbed by the baby. Though it is secreted into the breast milk, it is not absorbed by the baby. Okay. So breastfeeding in the postpartum period, desferrioxamine will be restarted. If she is not breastfeeding, then full chelation regimen will be given. So we will have the recap. T2 less than 10 milliseconds. That is the high risk for the cardiac failure. HB target should be 10 or more gram per deciliter in the pregnancy. Fructosamine is preferred over HbA1c. Desferrioxamine is safe after 20 weeks of gestation. Splenectomy, patient will require lifelong penicillin plus vaccine. FGR is common, so serial growth scan will be required. High risk of venous thromboembolism, so LMWH will be required postpartum. Okay. So important thing is that cardiac. So which condition has got a risk of cardiac iron overload? It is the thalassemia, and that can lead to cardiomyopathy. Best marker for glycemic control is the fructosamine. Okay, so best cardiac assessment is done with T2 MRI. Then fertility issue in thalassemia patient is a hypogonadotropic hypogonadism. Main treatment pillar is a blood transfusion and iron chelation, and these patients require regular blood transfusion. That is why there is increased iron overload. That is why these patients require iron chelation. Okay, so HbA1c for diabetes monitoring is not advised. Chelation is not safe in the first trimester. Pregnancy contraindicated always. No patient can become pregnant depending upon fertility status, and the case is to be individualized. Estrogen contraindicated here? No. Okay, it is allowed. While in sickle cell disease, estrogen is a second line. Okay, estrogen containing pills will be second line. Okay, so most serious risk is a cardiomyopathy. Best cardiac test is a T2 MRI, glycemic monitoring with fructosamine, iron target liver less than 7 milligram per gram, chelation to be stopped 3 months before conception, fertility issue is hypogonadism, and contraception. All methods are safe. Okay. So if we compare the sickle cell disease and thalassemia, here the pathology in sickle cell disease is a sickling that leads to the vaso-occlusion, while here in thalassemia there is a decreased globin synthesis. Okay. So the presentation in sickle cell is acute episodic, while it is a chronic and progressive in thalassemia. In sickle cell disease, there are crisis, pain, acute chest syndrome, acute stroke, etc. While it is anemia and iron overload that is common in thalassemia. Transfusion is selective, crisis based. Okay, while here it is a regular and scheduled transfusion which is required. Hemoglobin target in sickle cell is not very specific. However, we need to maintain hemoglobin 10 gram per deciliter in thalassemia. So key complication is acute chest syndrome in sickle cell disease, while cardiomyopathy due to the iron overload, and that is one of the important cause of maternal mortality also in patients with thalassemia. Chelation not regularly required in sickle cell disease, however, it is essential for thalassemia. Okay, stroke is common, and in this acute stroke, extended transfusion is required, while in thalassemia it is rare. Acute chest syndrome is common in sickle cell disease, it is rare. Okay, functional asplenia is seen in sickle cell disease, while these patients in thalassemia, they are at risk of infection due to post-splenectomy. Okay, thrombosis risk is moderate in sickle cell, while it is high, especially after splenectomy, and that is why these patients will require aspirin plus low molecular heparin if the platelets are more than 6 lakh and the patient has undergone splenectomy. Okay. So this is the same thing we have seen. We have already discussed this thalassemia, what is the central problem and all. So chest pain plus infiltrate, it is a sickle cell disease and suggestive of acute chest syndrome. Progressive dyspnea plus iron overload, that is seen in thalassemia, suggestive of cardiomyopathy. And sudden neuro deficit, that is seen in sickle cell disease, suggestive of stroke. Okay. So just to remember, in sickle, you remember that there is a sudden problem in sickle cell anemia, while in thalassemia, it is the overload problem. Okay. So if the question is acute scenario, think of sickle cell disease. And if the question is chronic optimization, then think of thalassemia. Okay. So that finishes the topic of thalassemia. Thank you.